Sarah Faubel from the University of Colorado, Denver and VA Medical Center, and also chair of the ASN-AKI Advisory Group. And I was asked to comment on preparing to do dialysis in patients with Ebola virus disease. And one of the first things to realize is that your hospital has to be prepared before you can start thinking about dialysis. And that requirement is having a biocontainment unit, a way to protect the healthcare workers with good protective equipment and practice with that personal protective equipment, and a way to dispose of the waste, and how the healthcare workers are going to be selected and who's going to take care of these patients. If your hospital is ready with the appropriate biocontainment facility, then you can start thinking about doing dialysis. And I think it's really important to say first off that we know that dialysis can be medically indicated in patients with Ebola virus disease, and given the example at Emory, it can be done safely. So it's really important to realize that the best protocol for your institution is one that incorporates your center-specific expertise. And the best protocol at one center isn't going to be the same as the best protocol at another center. So trust your ability to work within your center and your expertise. Everyone's asking for a specific protocol, but the protocol at your institution will look different from other protocols. And there's basically 5 main considerations when you're writing your dialysis protocols. One is to consider the effluent and how it's handled, line placement, where it's going to go and who places it, lab checks, how often you can check them and what labs you can check, anticoagulation modalities, and then the modality of dialysis. How do you handle the dialysis effluent? And really, it can go in the usual place. It goes down the sink or the toilet, and the issue is, does it need to be disinfected or not? The CDC says that you don't have to disinfect it ahead of time, and that it's very unlikely to contain the virus. But you have to check with your local wastewater department as well as local public health officials to decide if that's the case. I would recommend, if you don't have to disinfect the effluent, please don't, because it adds another level of procedures and steps to the dialysis procedure that is already going to be difficult in the biocontainment unit. The next consideration is line placement and where the line goes and who puts it in. The issues with line placement is the optimal place is probably the right internal jugular. However, you have to be able to check line placement with an X-ray. And if you don't have a dedicated X-ray machine, then that may not be a good choice. The femoral approach may be a better alternative if you can't do an X-ray, given that there may be increased infection risk in a patient with a higher BMI, or there could be potential for retroperitoneal bleed. Usually you're going to be doing point-of-care testing, and so not all the lab tests will be available, particularly phosphorus. And you're also going to have to think about how frequently you check those labs. In CRRT, we usually check a lot of labs, but you don't want your healthcare worker to be doing too many blood draws because that's a blood exposure. So you're going to probably reduce the number of lab checks, and you may have to do empiric electrolyte replacement. Basically, the idea here is use what you're comfortable with at your facility, and you may need to make modifications based on the lab tests that are available to you. Probably the best modality is continuous renal replacement therapy. In case the patient becomes hemodynamically unstable, it'll really be the best modality. And what you do is you pick one machine, put that in the room. It's going to be the dedicated machine for that procedure.